For small to medium bone segments requiring a low-profile implant, Auxein offers the solution: headless cannulated screws. Hand and wrist. Foot and ankle. Headless cannulated screw system is a range of orthopedic implants designed for fixation of small to medium bone fractures. The patient is positioned supine with the hand placed away, exposing the proximal scaphoid. The fracture is examined under an image intensifier to plan the percutaneous technique. Using the wire guide, a safe path for the guide wire is created while protecting soft tissues and median and radial nerves. A 0.8 mm guide wire is inserted through the wire guide along the central scaphoid axis. It is advanced until it reaches the distal cortex. Placement is confirmed in AP and lateral views. A second 0.8 mm guide wire is placed parallelly to maintain reduction and stability. With both wires secured, the wire guide is removed, leaving guide wires in place. A depth gauge is advanced over the first guide wire to measure screw length. The 2.5 mm reamer with quick coupling ratchet handle is advanced to break the cortex. Reaming is stopped 1 to 2 mm short of the articular surface. The 2 mm drill bit is guided over the guide wire into the bone. A 2.5 mm headless cannulated screw, 1 to 2 mm shorter than measured length, is selected. The screw is connected to the 1.5 mm hex cannulated screwdriver with quick coupling ratchet handle. The instrument is passed over the guide wire, and the screw is rotated clockwise to desired depth. After insertion, the screwdriver and guide wire are removed. The procedure of scaphoid fixation using Auxein headless cannulated screws is successfully completed. Auxein's headless cannulated screws are designed to suit a variety of surgeries. The following demonstrates medial calcaneal osteotomy using these screws. The patient is positioned supine with a thigh tourniquet applied. C-arm fluoroscopy is positioned for lateral and axial heel imaging. A lateral incision is made over the calcaneal body, distal and posterior to the lateral malleolus. The osteotomy site is marked on the calcaneus. A hook is used to expose the lateral wall and to create space for the blade through the small ligaments. The sural nerve and peroneal tendons are carefully protected. An oblique osteotomy cut is performed using an oscillating saw, from posterior superior to anterior inferior. The cut is completed in a controlled manner to allow medial shift of the fragment. An osteotome is used to displace the posterior tuberosity fragment. The posterior fragment is translated medially, 5 to 12 mm, based on correction needed, and is confirmed in lateral and axial fluoroscopic views. A 6.5 mm sleeve with guide is positioned for 2.4 mm guide wire insertion on the calcaneal surface. A 2.4 mm guide wire is advanced posteriorly, aiming plantar anterior, and confirmed under fluoroscopy. Another 2.4 mm guide wire is placed parallel to the first. The guide is removed, leaving guide wire intact. A depth gauge is advanced over the guide wire to measure screw length. The depth gauge is removed. For a 7.5 mm headless cannulated screw, select the appropriate size of the 6.5 mm cannulated drill bit. The drill bit is guided over the guide wire through the sleeve. The bone is drilled to prepare the hole for the screw. The drill bit is removed. The 7.5 mm headless cannulated screw with 4 mm hex cannulated screwdriver is passed over the guide wire. The screw is rotated clockwise to fix securely in the bone. Compression is ensured across the osteotomy site. The guide wire and sleeve are removed, and final tightening is performed with a 4 mm hex screwdriver. The screwdriver is removed after confirming fixation stability. The screw head is buried within the lateral cortex. Another 7.5 mm headless screw is inserted if required. The guide wires are removed. The medial calcaneal osteotomy using Auxein's headless cannulated screws is successfully completed. After scaphoid fracture fixation, the wrist is typically immobilized in a below-elbow splint for about 2 weeks to protect the surgical site. Pain and swelling should be adequately managed to facilitate rehabilitation. Patients should also be aware of potential nerve injuries. The healing process is a multi-phase journey, progressing through inflammatory, repair, and remodeling stages, with full recovery taking several months. Following a medial calcaneal osteotomy, postoperative care is crucial for a successful recovery. Initially, a cast or splint is used to immobilize the foot. It is vital to remain non-weight-bearing for 4 to 6 weeks and keep the foot elevated to manage swelling and pain. As the bone begins to heal, the cast is replaced with a removable walker boot, and a personalized physical therapy protocol will be introduced to restore strength and range of motion.